Hi guys, my name is Mina. I am also a third year medical student helping out with the farm reviews. We really hoped that you find these reviews helpful. So, Mike talked about the dynamics and the kinetics, and I'm going to talk about the prostaglandins and the NSAIDs. Um, with prostaglandins, I think it's really important that we understand what are prostaglandins and what do they do. So it really starts with inflammation. So if there is any cell that is inflamed, and you guys will talk about this a lot in pathology, it starts at the membrane lipids. And the membrane lipids, because any cell has a phospholipid membrane, it gets metabolized by this enzyme called phospholipase A2. And phospholipase A2 makes the substance called arachidonic acid. And when arachidonic acid gets made, it can go into two pathways. The first pathway is that it can make leukotrienes, and then the second pathway is that it can make some prostaglandins. So if it decides to make leukotrienes, it goes through this enzyme called lipo oxygenase, and it makes leukotrienes. So there's sort of two types of leukotrienes. The first type is leukotrienes B4, and that is important for neutrophil chemotaxis, and that will get mentioned in pathology. But then the other type of leukotrienes is leukotriene C4, D4, and E4, and that causes an increase in bronchial tone. So if you increase bronchial tone, it'll cause bronchoconstriction and it will cause shortness of breath. So that's the first pathway. The second pathway is the prostaglandins pathway, and there's two enzymes that make prostaglandins, so Cox1 and Cox2. And these make specific prostaglandins. And prostaglandins function on mainly two things, actually three things. The first thing is platelets, so it can either cause increase or decrease platelet aggregation. The second thing is smooth muscle, so mainly the uterus, so it can cause increase or decrease smooth muscle tone. And the third thing is vascular tone, so it can increase or decrease the vascular tone. So we'll talk. So these are the main functions of the prostaglandins, and then the last thing is that prostaglandins can also cause pain and inflammation. Hence, why we have Cox inhibitors to inhibit making prostaglandins. So with that understanding in mind, I put in a little summary because I know it can get a little confusing with the prostaglandins. So um, these are, I think probably the main takeaway from the prostaglandins that you want to keep in mind. So prostaglandins E1 decreases vascular tone, but it increases uterine tone. Prostaglandin E2 increases uterine tone as well, but it's also involved in the important part of gastric protection. So it increases decreases acid production and increases substances that causes gastric protection. And it also causes renal vasodilation. So that's prostaglandin E2. Prostaglandin F2 increases the aqueous humor flow. So in the eye, increases the flow of the aqueous humor. And then prostaglandin I, that decreases vascular tone. And finally, not prostaglandin, but more of like a cousin to the prostaglandin, but it's usually lumped in the same category, is thromboxane. So thromboxane A2 actually stimulates platelet aggregation. So if we have an understanding of prostaglandins, we can make drugs that mimic prostaglandins that can help us clinically, or we can decrease making the prostaglandins or the leukotrienes. So with that in mind, we can start talking about the drugs that mimic the prostaglandin. So the first one that we're going to talk about is prostaglandin E1, so PGE1, and the mimicker for it, or the drug, is called L-prostadil. And honestly, like in pharmacology, the biggest challenge that you will have is knowing the drug name. If you know the drug name, then half the battle is solved. If you know the mechanism of action, then 90% of the battle is solved. So that's what the first drug is called, L-prostadil, and it's used to maintain the patency of ductus arteriosus. So as we know, a lot of the children are born with a patent ductus arteriosus, and in some instances we need to keep it open until a surgical fix. is obtained, so alprostadil is used for that. It's also used as a second-line treatment for erectile dysfunction. So the reason it's used for that is because it causes vasodilation and it causes engorgement of the erectile tissue. So it leads to erection. So that's the first drug. The second drug is PGE1 analog. So that's misoprostol. So it's an analog to prostaglandin. And the mechanism of action is that it increases the production of gastric mucosa barriers and it decreases acid production. So it helps protect the stomach. And the second thing is that it increases uterine tone. So we can make clinical use of that is that we can use it to prevent NSAID-induced peptic ulcer. So NSAID decreases prostaglandin release, so we can give an analog that sort of can replace that, and it can prevent peptic ulcers. And then the second use is that it's used to induce labor by ripening of the cervix because it increases the uterine tone. The side effect to the misoprostol is making sense of all of it is that if you give a medication that induces labor, you don't want to give it to women of childbearing potential because it can cause abortion. It can actually be used in cases of abortion, misoprostol. The third medication is PGE2, which is dinoprostone, and it's very similar to misoprostol, increases uterine tone, and it used to ripen the cervix prior to induction of labor. So very similar mechanism. I'm not going to spend too much time on it. So the second set of prostaglandins is the prostaglandin F2 and I2. So when you think about the prostaglandin F2, think of the eye. These are the main medication that are used for glaucoma. So the suffix to it is prost, latanoprost, bimatoprost, travoprost, and carboprost. So prost is the suffix to it. And the mechanism of action is that it decreases the intraocular pressure. And how it does that is that it increases the outflow of the aqueous humor. So in the eye, the aqueous humor can build up, leading to increased intraocular pressure, leading to glaucoma. And these medications increase the flow of the aqueous humor. So it's used in glaucoma. That's the biggest use of it for it. The side effect is kind of a strange side effect. It actually leads to eyelash growth. So people have noticed that their eyelashes grow while using latanoprost, for example, and it darkens the color of the iris. And while you would think that this is probably not an important fact, I actually had a question on my step 1 exam that asked a patient has been using a medication that leads to their increased growth of their eyelashes. What medication is it? And they give you a bunch of options. And of course, the answer is latanoprost. Finally, last prostaglandin is prostaglandin I2, and that's epoprostenol. And how it works is that it vasodilates the pulmonary arteries and decreases platelet aggregation. So if you take that into context, if you want to vasodilate pulmonary arteries, what disease would you use that in? So the answer is pulmonary hypertension, because in pulmonary hypertension you have an increase or constriction in the pulmonary arteries leading to hypertension of the pulmonary circuit. And you also have some platelet aggregation in that disease state. So if you use epoprostenol, you can actually vasodilate the pulmonary arteries and you can treat the pulmonary hypertension. So Mike put in this picture. I am not sure who that person is. I think he's a famous player, but he has a congenital condition that has different eye colors, as you see, a blue eye and a brown eye. But it's just a visual reminder that these medications, the latanoprost, can darken the color of the iris. So this serves just as a visual reminder. So we talked about the prostaglandins. And we said, they have different functions. Next, I wanted to talk about the leukotriene. So I wanted to go back to our summary, and we have here this pathway, the leukotriene pathway. And what we want to block is these three, the C4, D4, and E4, because they increase bronchial tone. And how we block that is that can we either block the receptor by these drugs, zariflucast or montiflucast, or we can block the enzyme itself, so the lipo-oxygenase enzyme, but this drug called zelutone. So let's read it together. So the first one is the leukotriene receptor antagonist, is montelukast and zariflucast, and the suffix is the lukast. If you understand the suffix, it can make recognizing the name of the drug a little bit easier. And the mechanism of action is that it blocks the leukotriene receptors, thus blocking bronchoconstriction. The use, it's actually used in aspirin-induced and exercise-induced asthma or allergic rhinitis. And the reason why it's used in aspirin-induced asthma is because of a very specific reason. Let's go back to this, this slide. Let's say that you give aspirin to a patient, okay? And you give them the aspirin here. It's going to block quad enzyme. So it's going to block the Cox1 and the Cox2. So you're going to make less of these prostaglandins. If you make less of the prostaglandins, you're going to make more of the arachidonic acid. If you make more of the arachidonic acid, it's going to make more of the leukotrienes. And if you make more of the leukotrienes, you're going to increase the bronchial tone. So in some patient population, aspirin can actually exacerbate asthma. And in these patients where montelukast and zariflucast are actually used. So this is what I just mentioned here, that it's aspirin-induced and exercise-induced asthma. There's really not much significant side effects. The second agent that you can use is an enzyme inhibitor, what we talked about earlier. It's called zelutone, and it's 5-lipo-oxygenase inhibitor, and that just blocks the enzyme, blocks the arachidonic acid conversion to leukotrienes. Pretty self-explanatory as we had talked earlier, and it also has the same use as the leukotriene receptor antagonist. So that really ends the discussion for the prostaglandins and the leukotrienes. So going back and finishing our discussion, we talked about the prostaglandins and the leukotriene, and the last discussion is with the NSAIDs, so non-steroidal anti-inflammatory drugs. And why they're called non-steroidal is I wanted to kind of go back to the first summary page, and you can prevent inflammation by preventing this enzyme called the phospholipase. So these are you prevent it by corticosteroids. So steroid medication can also prevent inflammation, but the reason why these medications are used, the NSAIDs, is that they're non-steroidal. So you can prevent the inflammation. So non-steroidal anti-inflammatory drugs, so NSAIDs. That's where the name came from. So with that understanding in mind, we can delve in a little bit deeper about the difference between Cox1 and Cox2. So as we talked about, we start inflammation with the phospholipids, and it makes arachidonic acid. And arachidonic acid can get converted into prostaglandins by the enzyme Cox. So Cox has two subtypes, Cox1 and Cox2. You can think of Cox1 as the good enzyme or the helpful enzyme, and you can think of Cox2 as the bad enzyme, if you want to call it. So Cox1 is inhibited by aspirin or NSAIDs, and Cox2 is also inhibited by aspirin or NSAIDs, but it also has some specific Cox2 inhibitors. So let's say that you have arachidonic acid and it's going to get metabolized by Cox1. It's going to make constitutive prostaglandins. So these are some good prostaglandins that we want in our bodies. So actually maintain physiologic function. So gastric mucosal protection, increased renal perfusion, platelet aggregation. So some good stuff that we need the prostaglandins in. So potentially we want to not inhibit Cox1. Now, if you look at Cox2, these are the inducible, it makes the inducible prostaglandins. So mainly pathological functions. So increased pain sensitivity and inflammation. But in addition to that, it also has some physiological function that increases renal perfusion, vasodilation, and tissue repair. So the idea is that you can block either both Cox1 and Cox2 and decrease this whole thing, or you can specifically block Cox2 and you get rid of the pathology, but you keep the good prostaglandins. So that's the idea between Cox1 and Cox2. Just wanted to get that out there because you'll hear them talk about Cox1 and Cox2. So with that in mind, we can delve into the specific agents that are used. So aspirin is the first non-steroidal anti-inflammatory drug, and the mechanism of action is that it inhibits Cox1 and Cox2, but the key thing is that it's irreversible. Again, very important that it's irreversible, and the reason why it's irreversible is that it uses covalent acetylation. And maybe when you do UR a little bit later, you'll find that they may ask you how does it actually irreversibly inhibit the enzymes by acetylation. So if you do that, then you're going to decrease prostaglandins. As a side effect of aspirin, you're also going to decrease the synthesis of thromboxane A2. And if you remember what thromboxane A2 was used for, is that it was used for platelet aggregation. So with that in mind, you can go into the uses. So uses are divided into low dose, medium dose, and high dose. So low dose is less than 300. It's actually used as an antiplatelet agent because we've already established the fact that it decreases the synthesis of thromboxane A2, thus decreasing platelet aggregation. So it's used in MIs, heart attacks and strokes, CVA, cardiovascular accidents. Medium dose and high dose are actually not used clinically anymore because we have better agents, but it's mainly as antipyretic and analgesic, and the high dose serves an anti-inflammatory. The side effects of aspirin is probably what you're going to be tested about and what you'll be pimped about in in rotations or anywhere. So it's very important to know what are the side effects of aspirin. So the biggest side effect, or one of the most important side effects, is that you get bleeding. And it makes sense because if you decrease synthesis of thromboxane A2, you're going to decrease platelet aggregation and you're going to have bleeding because you inhibit the platelets. And that effect lasts 7 days. And the reason why it lasts 7 days is because, again, it's irreversible. So it takes about 7 days for the platelets to form. In addition to general bleeding, you have specific GI bleeding. And the reason for that is we established earlier, I apologize, that you inhibit prostaglandin E. And prostaglandin E is protective for the gastric mucosa. Other side effects that are not related to bleeding is you actually get tinnitus. So it's related to cranial nerve 8. I'm not sure of the exact mechanism, but that's a very, very important clue, either clinically or in questions. You'll get a patient, you'll say that so-and-so was taking a medication and they got tinnitus. What is a possible medication that the person is using? And that answer is aspirin. And the next high-yield side effect for aspirin is you get Reye syndrome. So Reye syndrome is this funky disease, and it's mainly in children with viral infections. So back in the days, kids with viral infections that were febrile, they would give them aspirin. But they noticed that these kids got really sick and they got hepatic encephalopathy. And it's because of aspirin-induced Reye syndrome. So aspirin blocks the mitochondria, and if it blocks the mitochondria, it causes toxin accumulation, and you get hepatic encephalopathy. So you do not want to give kids with fevers and viral infections aspirin because they will get Reye syndrome. So that is something that you will definitely be tested about Reye syndrome. Now let's go to overdose because that's also something that's important. So aspirin overdose, you'll get a bunch of things. You'll get tinnitus, of course, but you'll also get acid-base disorder. So the first disorder that you will get is that early on you'll get respiratory alkalosis. So the PCO2 will actually drop because aspirin directly stimulates the respiratory center. So you'll have hyperventilation. So you'll get respiratory alkalosis. And late you actually get anion gap metabolic acidosis. So very high yield that it causes both respiratory alkalosis and anion gap metabolic acidosis. And the treatment of overdose is actually very simple. So aspirin is a weak acid, and if you want to keep it in the urine and not getting absorbed, you alkalinize the urine so that you keep it in in the ionized state. And I believe Mike had talked about acid base as in the dynamics. So that's an important concept to be aware of. So that's the first medication. I spent a lot of time on aspirin because it's very important and you'll get a lot of questions on it. The second agents is generally the NSAIDs. So ibuprofen, ketorolac, these are medications that we've all taken when we have a fever or we have pain. And we've already talked about the mechanism and inhibits Cox1 and Cox2. It's used for fever, any inflammatory condition, because we know that they block inflammation. Specifically, endomethacin is used to close the patent ductus arteriosus, because we've already established previously that the patency depends on the prostaglandin E, and we can give L-prostadil to keep it open. But if we want to close it, we can give endomethacin. Side effect, as we have established, is that it can cause GI bleed because of blocking of Cox1. You can get interstitial nephritis, and you'll learn that about in pathology. And you can also get renal ischemia. And the reason why you get renal ischemia is because the prostaglandins vasodilate the afferent arterioles. So the NSAIDs do the opposite. If you vasoconstrict the afferent kidney arterioles, you're going to get ischemia. So this is just a summary of NSAIDs side effects. Here you have the arachidonic acid, and then you have the effects on the different systems. So GI, kidney, or cardiovascular. So GI is mainly affected by Cox1 because it makes prostaglandin E2. So if you inhibit Cox1, you get peptic ulcers and GI bleeds. Cox1 and 2, that has the main effect on the kidney. And inhibition causes hemodynamic acute kidney injury, and it also causes some sodium and water retention, but it's not as high yield. And the last thing is that you can have cardiovascular side effects. You can actually get stroke and myocardial infarction because you are causing inhibition of platelet aggregation and vasoconstriction. So these are the main side effects for NSAIDs. Now specifically we can talk about the Cox2 inhibitor. So the main one is Celcoxib, and we know the idea is that it selectively inhibits Cox2. So it actually spares Cox1 and the PGA2, so responsible for maintaining the gastric mucosa, but it inhibits prostaglandin E2 and I2, and it's which is responsible for pain and inflammation. So the use of Celcoxib, which is the Cox2 inhibitor, is that it's used in osteoarthritis in patients with previous or high risk of GI bleed, which makes sense. If I have a patient with a high risk of GI bleed and they have osteoarthritis and I want to give them a pain medication, I can potentially get that medication, Celcoxib. Side effect for it is that you actually have an increased risk of thrombosis because actually that's a point that I failed to mention earlier. Thromboxane is spared because thromboxane depends on Cox1. So if you don't have Cox1, you're going to make thromboxane. And if you make thromboxane, you're going to actually cause platelet aggregation and eventually thrombosis. So they found that Celcoxib have an increased risk of myocardial infarction, and that's a point that's very high yield for examinations and for the boards as well. And finally, our last slide will talk about acetaminophen, our most used drug. It's very popular, and we usually lump it under the NSAIDs, but it's really not an NSAID. We don't know how it works, so you will not be tested on it. Potentially, it can reversibly inhibit COX. But the biggest things about acetaminophen is the side effects and the mechanism of the dose. But let's talk first about the use. So use can be used for fever, pain. You all have used acetaminophen before. The important thing is that it's not an anti-inflammatory. Again, it's not an anti-inflammatory because it doesn't really inhibit prostaglandins. Side effects for acetaminophen, it's very mild. the important thing for acetaminophen is the overdose. So as we all know that acetaminophen overdose leads to liver failure. And the mechanism, the exact type of liver failure is that it causes hepatic necrosis, so central lobular necrosis, and you learn about that in pathology. And specifically, the risk increases with alcohol consumption because alcohol induces CYP enzymes and it causes glutathione depletion. So I wanted to delve in a little bit deeper into the type of the mechanism of overdose because you'll get pimped a lot about the mechanism of the overdose, and I believe you can get asked questions in pharmacology or pathology or even biochemistry about the mechanism. So if you sort of understand it logically, acetaminophen goes into the liver, and it goes to the liver and says, hey, I want to be metabolized. So it gets metabolized by these enzymes, the CYP450 enzymes. However, one of the metabolites for acetaminophen is toxic, so it's called NAPQI. So it leads to reactive oxygen radical species leading to injury. How we get rid of this NAPQI is that it gets conjugated to glutathione, and that's how it gets excreted from the body. So the story goes, acetaminophen goes to the liver, makes NAPQI. NAPQI is toxic, and it goes and kind of hooks up with glutathione, and it tells glutathione, okay, let's get out of the body. The problem is in overdose, you have a depletion in glutathione, and if you have a depletion in glutathione, you get more reactive oxygen species, leading to liver necrosis. Very, very, very important high yield point is what is the antidote for acetaminophen? The antidote is a drug called N-acetylcysteine, and the whole point of N-acetylcysteine is that it actually regenerates glutathione. So very important discussion with the acetaminophen. With that, we conclude our section. I know we covered a lot of things. If you have any specific questions about NSAIDs or acetaminophen or any of that stuff, or anything in particular, please let me, myself, or Mike know. We're more than happy to answer your questions, and hopefully we'll get a time to give you the review sessions in person, and you can interact more with us. Hopefully you guys have learned something from this, and best wishes on the exam. And again, please let us know if you have any questions.